So I'm Steve Hollenberg. I'm from Hackensack. My co-moderator is Jason Katz from Duke. And I'm honored to be here, and I have the honor of being the first person to thank Marwan for organizing this conference, and I'm sure I won't be the last. So we have a panel of distinguished panelists to my left, Dr. Carr from Houston, Dr. Walsh from Penn, Dr. Rao from Duke, Dr. Rameh from Jefferson, Dr. Schrager from Germany, and Dr. Boskert from Baylor, I think, is running a little bit late. And we have a very interesting panel of speakers, and our first is Dr. Nir Uriel from New York-Presbyterian system, and he's going to talk about where are the cardiogenic shock guidelines.
So good afternoon, everybody. I have to say, first of all, Marwan, congratulations. First meeting after the pandemic to have a full room, full faculty, and such an impressive panel that is going to be talking today. I'm actually very honored to speak here today, and thank you for the kind invitation. I have to say, when I look at the title, I said, whoa, I can finish it in one slide. Where are the guidelines? I don't know. So hopefully I will, in the next 15 minutes, will be able to convince you a little bit about this. This is my disclosure. So we are going to speak about how do we make guidelines, because this is important to understand. Medication, cardiogenic shock, and where do they sit in the guidelines. A little bit about AMI guidelines and cardiogenic shock, because those are a little bit better. And approach to mechanical circulatory support, because we are going to speak a lot about it. And eventually, what is the future of guidelines? I'm just going to give you a taste, okay? This is an opening to what we are going to hear in the next 2 days. When I read the agenda was so beautiful, I said, I just need to remind each one what we are going to learn in the next couple of days, and that's what's going to be. So it's not going to be deep, it's going to just give us something to think about. So this is guidelines. What is the essential component when we want to build the guidelines? We want first to say, what class of recommendation are we? Are we speaking about class 1 recommendation, that is a stronger recommendation, you should do it? Are we speaking about class 2A, that we suggest that you will do it, it's reasonable? Class 2B, yes, you can do it. Or class 3, never do it. That's the first thing. The second thing is based on what? Sometimes I can sit in the room with Dan and we can brainstorm together and we said, you should do it. But sometimes it's not. This will be class C recommendation, expert opinion. But when we want to really speak about guidelines, we're speaking about level of A recommendation that we have multiple, not only one, randomized study that support the same concept. Give you an example. We have an SGLT2 inhibitor. We have multiple studies supporting the same concept. Class B recommendation can be divided into two. One big study that is dominant, or actually multiple studies that have some degree of recommendation. And as I said, class C is expert opinion. The reason that, and I hope that I will convince you throughout, is that when we are speaking about all those strong logistic and methodology and the quality of the data on those studies, it's important to ask ourselves how we do research in cardiogenic shock, and of course we're going to have a talk about it. So, first thing, when you have a talk like that, what you do, you go to PubMed. And when I went to PubMed, wow, 17,000 papers and 288, okay? There is no doubt, there is no way I can review all those papers preparation for this talk. But if I did another word and said randomized control study and added into it, suddenly, I have a lot of time to go to the beach before I'm preparing this talk. And that's the reason, and already we understand where the guidance is. So 17,200, and look at it, it's mostly lately. Cardiogenic shock became a major issue in the last few years. It's not that the statistic of cardiogenic shock was different, and we have a talk about epidemiology, so I'm not going to speak about it. It's actually we have tools to fix cardiogenic shock, so we study them and we study them better. So let's dive in. What we need to do in order to do a study, a good study, we need to make sure that we are not falling in the holes. And there is something that's called reverse Swiss cheese model. Actually, the holes is bigger than the cheese. And I think cardiogenic shock have a little bit of it. We have a lot of studies that are small sample size. Randomizing unstable patient. We have heterogeneity of inclusion criteria. We'll talk about it. Complex logistic, ethical dilemma, and inconsistent definition. So how can we talk about guidelines when this is what's happening? Cardiogenic shock started with big hole. We need to close the holes before we do the guidelines. So let me give you an example, evolution of cardiogenic shock definition in a clinical study. And this is a nice example. We have the shock trial, something that is seminal, that done by Judith Hochman. So we talk about systolic blood pressure less than 90 with more than 30 minutes, evidence of end organ perfusion. And hemodynamic criteria with cardiac index below 2.2 and wedge above 15. If I will go on a different shock study, I can find different criteria. It depends what I'm choosing. So when I'm starting comparing those studies, I'm not comparing orange to orange. I'm comparing orange to apples. And that's something that is important for us to remember. So the first big thing that happened in the last few years that is so important, we have a classification. We know that not all cardiogenic shock is equal. And I'm looking at a few of the people here in the audience, and Marwan, you brought them in, so they're going to speak in length about it. But finally, we can say we have cardiogenic shock that's just at risk. We have cardiogenic shock in the beginning. We have cardiogenic shock that are classic. We have people that are deteriorating, and we have people that are extreme. So maybe each one of those groups need a different study. And maybe our utility, and we not need to speak about guidelines to all of them together. This was a big jump that we really understand, and we'll hear about it more. But what more we understand is that now, if we have the A, B, C, D, E, we need to look at about them in a context of what we know in our world of cardiology. We know to see what ACC class the patient are, C or D, in this regard. We know what neurocard association those classes are. We want to know what intermax they are. And we now think about all of it. In order to create all those cardiogenic shock studies, we really now need to understand where the patient is, and then we do guidelines based on this patient. So this is a classical algorithm. You're all familiar with it. Started with Judith Hochman many, many years ago. We have a lot of lines. So we have diuretics that we can give, and we have ventilation, and we have inotrope and pressor, and mechanical circulatory support, and reperfusion, okay? So where are the guidelines on each one of them? And that's what I'm going to do in the next few minutes. First of all, medical therapy. Of course, it's IV. There is no medical therapy here that is not going to be IV. We're talking about shock. We have a lot of medication. We know how they work, how the dopamine or epinephrine or butamine. Just to show you, actually only now we start having some studies. Yes, you can kill this study. It's a simple study. But it still was a randomized effort to take milrinone against butamine and to see the difference in cardiogenic shock. It's a randomized study, it's a single center, so there is still some caveat here. But only now we have a study on medication that we all give in cardiogenic shock for 40 years. So that's the way the guidelines is. Another classical example to the medication. Only now we have a study about epinephrine versus norepinephrine. This was a randomized study that was stopped, okay? Because they showed that there was much more refractory shock in the epinephrine. So immediately we learned that we can stop arguing about epinephrine or norepinephrine. We need to give norepinephrine if we need a vasoconstrictor, okay? So this is just another example. But all those studies look at them, 2018, 2021, and those are medications that forever. And there is more medical study that's finally coming up. Sometimes we argue if to give steroid. Sometimes we want to give if the new biomedical therapies that exist in cardiogenic shock, actually we can block them, and maybe even we can go into the heart failure medication like Entresto. All those studies are finally coming. And where are the guidelines? This is the guidelines for medical therapy in cardiogenic shock. First of all, I don't see any 1 here. I don't see any 2A here. I just see 2B and 3. And only 2 of them have a class A recommendation, and let's look at them. Inotropic agents are not recommended unless patient is symptomatically hypotensive or hypoperfused because of safety concern. So it's a class 3. This is where we have data. So this is something just to show you. There is no guidelines right now on medical therapy. There is some very vague recommendation because the studies are coming now and hopefully they will come in soon. So let's go to the next topic of guidelines in cardiogenic shock, AMI shock. Big topic. First of all, again, definition, and I have to give it. This is a field that had the most amount of work in cardiogenic shock on it, there is a very clear definition. There is hypotension definition. There is an evidence of end organ perfusion definition, and there is the cause definition. So here people invest a lot of effort. This is coming from the guidelines. When you talk about cardiogenic shock AMI, it's not every AMI with shock mean that it's AMI shock. You need to fit those guidelines criteria. And I'm jumping a few ahead of time, and the most recent study about cardiogenic shock and reperfusion is, of course, the culprit shock study that show that actually if you do multivessel PCI, you actually can get into a little bit more trouble, and you better do stage PCI. So now we have a lot of data, and we can have guidelines. And that's where the guidelines of AMI shock. We have guidelines of emergency invasive angiography, 1B. We have guidelines of immediate echocardiography, 1C, because nobody did a study. It's obvious, so it's only expert opinion, but it's 1. We have emergency PCI to the culprit lesion, it's 1B, because only the culprit study for the meanwhile and a little bit of meta-analysis. But we also have some class 3, don't forget to do the PCI. So this is where the guidelines, and of course we'll speak about the pulmonary artery, and this is a classical guidelines algorithm that is based on data. The same is true for right ventricular failure. So if you have cardiogenic shock RV failure, you can also see the guidelines here. There is a guidelines. There is a guidelines array, again, to do angiography, there's a guideline to do echoes, there is a guideline to do fluid challenge. All of those are in the guidelines based on data that was collected. And of course, if we have a mechanical complication, again, the intervention cardiology did a lot of multi-center study about AMI. So the AMI have the panel of the shock inside of them. So we have a lot of information. How do we need to do when we have a severe MR that's happening due to a cardiogenic shock? What we need to do when we have a ventricular VSD that happened after cardiogenic shock? Those are all in the guidelines. And now we start having a guidelines that is 1. Again, most of them, as you can see, unfortunately, C. Expert opinion. It's still, we can sit in the end of the day and write the guidelines, okay? This is not something that is based on data. But in the bottom line, eventually, we want to start collecting evidence of data. And this is the classical example that now in the treatment algorithm to revascularization, we really have a nice information. We have a wealth of information. So in this wealth of information, we start having a 1B indication to do one vessel or only dealing with the culprit, do stage and send to emergency bypass, and it's going to be only 2A guidelines, C, okay? But we all know cardiogenic shock deteriorates, and we all have a lot of devices. So how do I choose the devices? Do I have a guidelines to choose a device? So I know that in the next 2.5 days, we're going to go through all those devices, the Impella family, the intra-aortic balloon pump, tandem heart, and of course the VA ECMO. And each one of them behave differently. How do I choose? Do I have a guidelines that tell me which device is going where? No, but I have a guidelines that tell me when I need to go there. And this is as important, and I will explain why. Sometimes we learn already that time is myocard in AMI. We know today that time to mechanical circulatory support in cardiogenic shock is life, not only myocard, it's life. So to know when we need to consider an individual to mechanical circulatory support and where the guidelines will support me based, and this is now can be done because David and other people did classification to cardiogenic shock, we can start saying if a patient is in C, start thinking about it. D for sure, E for sure. So that's the guidelines where it's come to help us. Do we have study to support it and where the guidelines here? I will show in a second. Yes, we have study. This is the balloon pump study. They didn't show any differences. So how do we choose? So all of it, again, based on some guidelines. We have RV dysfunction predominant, LV dysfunction predominant, oxygenation, and we have all those devices that can, some of them can do both, some of them can do only RV, only LV, and LC oxygenation. So that's the algorithm overall that we want to look. And eventually, this is right now the recommendation. We can't give guidelines. We can give a recommendation because there is no randomized controlled study, not even one, to check ECMO versus this. Right now, we will have them, but not until now. So there was a trial balloon pump, Impella. This is the IMPRESS study, as you know, that was a negative study. It didn't show any difference between Impella and balloon pump. And the reason that it was negative because we didn't know which patient population we are choosing. So maybe we need to choose a different patient population. And because of it, there is a different study right now that is ongoing. That is the German study, cardiogenic danger shock, that is ongoing. And Finn probably will give us a little bit of information about it. But definitely, we need to do study when we understand the patient population. Then we can do guidelines. However, if we already put something in, how can we treat it? I choose an ECMO, because Marwan liked ECMO, and I said, okay, you want an ECMO, put an ECMO in. Should I put an Impella or not? We don't have anything to say to us if to put an Impella yes or no. We have just, again, a cohort study, not a randomized study, as you can see here. This is but what is important to remember, that whenever we do those studies, it's so hard to recruit, and the selection bias is so tough. So don't expect to see it. And this is a classical study about hypothermia that we are going to talk, that's going to show you that maybe hypothermia is beneficial, but as I showed before, it's less than a third of this patient that were enrolled into the study went into the study. From 900, there was a event. So where is the guidelines? The guidelines is somewhere here, in this room. Right now, the guidelines is expert opinion, because this is the only studies that are randomized study that were conducted. We need guidelines. So thank you very much for your time, and hopefully we can discuss and have a nice discussion about where are the guidelines.
Thank you. So great talk. So we'll leave you up here. I would invite people in the audience to come up and ask questions, but we also have a panel, and I guess I'll start at my left with Dr. Carr, and we'll go down to the left, and we'll ask the panelists for questions and comments. I've got questions.
Great, Yuri. That was a great talk, and nice opening for the conference. But you highlighted two things. I think the fundamental problem that we have is, out of everything else that we treat in medicine, shock is the most heterogeneous group of disorders put together, which is very dynamic. It is not a static condition like most other places where you have classifications for diseases, which are static in time. Cardiogenic shock is changing minute to minute, second to second. And any classification that we do has to capture that. And when Marwan got up and said that shock algorithm, acronym that he wants to use is just to put those kinetics of shock into the classification of shock. Otherwise, just giving a snapshot of a shock at a certain point in time is not a true representation of the entire shock spectrum. So I think we have to get to that. And the second is the randomization, although to get into a class 1 recommendation of anything, you need randomized controlled trials. But ethically, how do you randomize a patient? For example, if a patient's father is in cardiogenic shock after an MI, you put a balloon pump, and now he's not doing well, his lactates are going up, his urine output is dropping. How do you go tell him, let's enroll you in a trial where there's a 50% chance of you staying in what is not working, and then a 50% chance of maybe a device which may work? That becomes a huge ethical problem. In fact, I have and others have gone to FDA several times about doing a propensity matching, because there are centers which cannot provide this devices, like in Canada and some other places, that we do propensity matching and then see the outcomes, because randomization in this condition will be almost ethically impossible to do.
I have to agree with you, Dr. Carr, and I think this is the main issue. We are ethical when we treat a patient, we don't want him to die. It's not okay. You assign to this arm, and if it's not working, bye-bye. We understand cardiogenic shock is different than if you enroll a patient to a medication study that you don't see it, rather than it's taking time. And that's the reason we as a community need to accept that the guidelines here doesn't have to be a class 1 recommendation. And the guidelines here doesn't have to be a class A or B recommendations. They can be C. However, what we need, and again, I want to congratulate a few people in the room here, we need a big cohort. We need to really understand in a non-biased way how cardiogenic shock behave, because we know that we are going to try to change it. And that's the reason we will not reach those guidelines. And that's the reason we are so behind. Meaning there is now, as you know, the cardiogenic shock working group. And the cardiogenic shock working group is actually collecting data on thousands of cardiogenic shock, and maybe we can start having really information. And that's the reason we have classification. We start having a good cohort, like the cohort that I show about Impella versus not Impella in VA ECMO patient. It's a good cohort. For me, I'm putting Impella now based on this study. Okay? Jason?
I've been waiting to talk to you for a little while, Nir. It's good to see you here. Truth be told, the very first Houston Shock Symposium, I was asked to give the same talk. Where are the cardiogenic shock guidelines? Or what can we learn from the cardiogenic shock guidelines? And I did have one singular slide where I said, there are no cardiogenic shock guidelines. We can't learn anything from them. And it's sad to see how in 4 years' time that we really haven't evolved a whole heck of a lot. But a few things, and you gave your talk considerably better than mine 4 years ago. But I'm struck by a few things you said, including the abundance of level 3 level of evidence. And it strikes me that cardiogenic shock is very different than anything we've really tackled as a cardiovascular community. It's very similar to what we've tackled. You know, I'm a cardiology intensivist. It's very similar to what we've attacked from a critical care perspective, but we've not been particularly successful in the critical care world. Outside of showing that over-treatment is harmful, right? High tidal volume ventilation is harmful. Targeting supraphysiologic hemodynamic endpoints is harmful. Doing more than the body needs is harmful. So I guess I would ask, like, how, you know, it's been 4 years since my talk to your talk. How confident are you that 4 years from now we'll have cardiogenic shock guidelines? And B, do you think the preponderance of guidelines are going to be don't do this, don't do this, don't do too much to the patient, don't outsmart the body?
So Jason, first of all, I'm sure that the talk was awesome. That's number one. Number two, I will say one thing. I'm an optimistic from whoever know me. I really believe in optimistic. And if you want to take a slide, take the third slide that I show. PubMed, cardiogenic shock. The number of studies is going up so much. The information that we collect now is so good. I do think if Marwan will want me again and will give me the same tackle again next year, we'll have much more information. I think the ECMO study in Europe is going to be finished. I think the Danger study, Denmark-German shock study, is only 120 patients for finished recruitment. I think you're going to have a lot of data. Now, by that being said, if you tell me, Nir, don't do this because it's dangerous, this is for me a guideline, and a good one. Because the last thing we know as a physician, first do not harm, primum non nocere. That's the main message in medicine. So if I'm doing things that harm the patient, and you tell me in the guidelines, Nir, don't do it, it's harm, you make me a better doctor because primum non nocere is one of the core of our existence.
Nir, I have a quick question. So, you know, being at Penn, and seeing a classification D patient, I can treat them incredibly aggressively, but then you have somebody in the community that has a stage D patient, and they don't have the resources that we might have. I think we need to come up with some guidelines for the community as well, other than try and quickly get them to your academic center.
So that's actually very important, and again, I have to say in the cardiogenic shock, and that's the reason I focus on the AMI shock. The reason that the AMI shock guidelines are so much with content, because the interventionalists did a very good job of actually doing randomized control study and collect data. One of them show, take your patient and do an early PCI as fast as you can. Not one of them, multiple of them. So I think in cardiogenic shock, probably the spoken hub that's going to have different guidelines to that. What you do until you transfer. Should you actually implant the patient, put the ECMO in the satellite sites and then transfer the patient when he's more stable or not? I have to say, this is a fascinating study that we can do. Yeah. Meaning transfer a patient immediately to a center or go with all of us in the big center, have a mobile ECMO unit and go implant the ECMO. This is a classical study. I agree with you. We obligate it to the community because if we're honest with ourselves, we are seeing usually the cardiogenic shock that starts after us. The minority of the patients have the cardiogenic shock established in our center as a tertiary center.
Because we have to be good stewards of this technology, right? We always want to make sure if we're putting somebody on advanced MCS, they have an exit plan, not just throwing everybody on MCS.
And Jason, I promise you, I will give you time to talk after that.
All right, welcome, Dr. Bosker.
Thank you, thank you. I'm going to go back to Dr. Carr's statement about the dynamic nature of shock, and thus our bedside role of minute-to-minute titration not being able to be translatable to the traditional trial design. And therefore, back to the last comment you said, the threshold to refer to be a potential design being a more practical approach to what kind of guidelines do we want? We don't want a recipe for minute-to-minute bedside titration because it's too many. And even in, if we take the hemorrhagic shock and what other, specialties have done, they didn't try 2 units of blood versus 3 units of blood. You start with perhaps the big gestalts. I think we have a sort of a developing shock to shock threshold that we don't know what that is. Maybe we need to focus on that threshold and go back to Dr. Carr's concept of maybe the staging as it currently stands created the forum, but we need to now recognize reversibility, the milieu by which this shock created, the trajectory, the dynamic nature of it, and come up with that threshold beyond which you refer. And then look at the outcomes if you're able to define that. So I think the guideline development, if we were to try to develop a recipe for every stage, I'm not so sure would be feasible because at this point we're not even with some standardized criteria for each stage. We just have a gestalt on trajectory.
So, Bikram, I'm 100% in agree with you. And the only caveat that I have is why do we have guidelines? We have guidelines because not all the physician is Bikram. Not all the physician is Dr. Carr. And we have guidelines because some physicians are a little bit, have less technology around them and less academic around them, and they need help. I need to decide 1, 2, 3, 4. Now, I do think that we have an opportunity, and I look at David now because with the new SKY criteria, the 1 minute to 1 minute change are very dramatic in SKY E. I think in SKY C we have a little bit of time. I think in SKY D, it depends, but I agree with you 100%. I want to work on my gestalt, but I don't want to be in the hospital 24/7.
I would propose to move the D to B. If you're in B and you're going in the wrong direction, you are referring. I think that's the part. The trajectory definition needs to be embedded in earlier.
Agreed.
And that's when you refer, not when it's too late, when it's futile.
And Nir, I would argue that you are, and I'm sorry.
No, please.
I would just argue that we don't have data that C is so stable. That's what's interesting.
Correct.
Is David came up, and Baran and the team from Sky came up with an amazing, very apropos to heart failure staging, apropos to heart failure, because we're heart failure doctors as well. But the timing, and again, Marwan, I think you're going to have to spell shock backward, which is Kosh, so you start with K next year. I'm just joking. But I can tell you that C may be one of the most dynamic, because how frequent do you check a lactate? Every 4 hours? Do we even have a guideline for that? I was just going to ask Steve with respect to intubation, if maybe for the next several sessions you can talk to us a little bit about what guidelines, and Jason, do we have for intubating the acutely shocky patient when you don't want to take away, it's what Biswajit or Jason said, you don't want to take away their natural survival instinct. And I would love to see some data on that, because I just had a case last night of someone that survived because of a great intensivist, pulmonologist that did what she thought was right, and she was right, and we were wrong. So anyway, look forward to hearing.
Anyway, thanks so much, Nir, in order to keep us on track and not get on Marwan's bad side so early.